You ready? Well, yeah. So we're going to do the countdown, and then you're going to be on.
Okay, and then so as soon as it counts down, I'm guaranteed to be live.
Yeah. As soon as you see yourself on the screen, you're live.
Okay, then it starts to scroll the bottom mark, and I'm always looking out here, then it comes up the whole screen. I feel more comfortable.
Yeah. I haven't figured out that shit. Why that happens. Yeah.
So it just, okay.
Okay, ready? 10 seconds? 10 seconds?
Let's go.
All right, going offline.
Welcome to tonight's feature, Ask the Testosteronologist. Tonight, I am your testosteronologist, Dr. Thomas O'Connor, and tonight I'm putting a topic that is very interesting, that is so usual that we see coming out of the anti-aging testosterone clinics in America for decades now. It started about 20 years ago. It's called the testosterone trap, I call it, right? And it's why more is not better. Okay, why more is not better. So let's talk about that. So, and I think it's amazing, right? So Americans, we like things big. There's no question. We like things big trucks, big meals, right? And that's great. I'm a huge American fan, guys, all day long, and that's the damn truth. But when it comes to supersizing testosterone with your clinic, you're going to have to take the drugs from them and really figure out how to do it yourself. Because let me tell you what's going on. So the why testosterone is not better, why more is not better, is very important when you understand the issues of what happens when you take too much testosterone. So most clinics still start men off with 200 milligrams per week of testosterone cypionate, typically, sometimes even more. And then they start to prescribe other medications, right? Polypharmacy. And it is a trap, I think, in essence, that most men that go to these clinics, they're not ardent, experienced steroid users, right? This is again, these are the kind of anecdotes I have for you guys, and kind of the essence of my gut, my visceral gut, for over 20 years, and really working in this industry, from the ground up, in the streets up, in the gyms up, right back in the day, from the 1980s, guys, way back. So the trap becomes that you get high dose testosterone, and then with that you get more complications, including high estradiol. Then they give anastrozole, right, which is a very powerful medication for breast cancer for women. I remember a guy one time came to my practice years ago, and he said, "Doc, I'm here because my wife is making me come here." And he said, "Here's what happened, Doc. I'm a 50-something-year-old guy, found one of these anti-aging clinics, and is really important that he treated himself, but he didn't want to tell his wife. So his wife figured something was going wrong, didn't really know exactly what was happening, didn't really trust the guy. He was acting weird. And then, of course, he's on testosterone, and she sees him getting really puffy and bloated, and he was more sexual, and she was worrying, right? So imagine his life versus her life, and he's keeping her in the dark. He's not telling her about this, and he wasn't a steroid using guy. And then she found his stash. She found testosterone cypionate, and she saw that, injecting it. And then she saw the anti-aging stuff. She saw medicine, anastrozole for breast cancer. She looked up that in the internet. We had an internet 15 years ago. And then she looked up clomiphene for fertility, and she came to the guy, and it's really a funny story. She kind of grabbed the guy by the neck and was like, "Get your lawyer, buddy, lawyer up. So you're cheating on me with a woman with breast cancer, and you're also trying to get her pregnant." I mean, it's a true story. So, not saying you can't use these medications, but a drug for a drug for a drug, you better understand what you're doing. So next is, with all that testosterone, high hematocrits, what do? Blood donation. And again, they don't all do it, but this is, again, testosterone too much. What's going to happen? Acne, antibiotics, and they always blame the acne on estrogen, which is not just estrogen. It's you as a human. You're going to go through you're going through like a secondary puberty on steroids potentially. And guys who have never had acne usually won't have too much of a problem, but maybe they do now because they never produced this amount of testosterone from their testicles when they were going through puberty. But if they did and they had acne then, it's going to be 10 times worse. So then again, it's not just estradiol. It's not just DHT. Okay. But it's all this milieu on the sebum, right? So that's when you understand the dermatological side of acne and your genetics. Again, rabbit hole stuff. So the next piece is, more testosterone doesn't mean better health. That's for damn sure. So more testosterone doesn't necessarily at all increase energy or libido or mood. It actually can make it worse. And a lot of guys find that the wrong way. And there's one thing that will gain, and that's this. I mean, there's no question that the more you take, you're going to get a bigger bench, squat, deadlift, whatever you're looking for in muscles. But is it quality muscle, and is it something you're looking for? Are you a bodybuilder? Are you a pro powerlifter or a strongman? And again, I love those guys, and I'm a harm reduction. I have a harm reduction hat for those guys. For most guys here, they're here tonight and are watching my videos nowadays. It's about loving and enjoying your life for as long as you can with the highest quality of life. And testosterone, yeah, that's gonna be part of your life, but you're never gonna have, you're gonna come off it. So you're gonna have to just put the phone down. All right. So thank you guys. So you're never gonna come off testosterone. You're never gonna come off testosterone. You have to understand that the cardiovascular aspects of what's going to happen are very, very important. So excessive blood pressure, the erythrocytosis, the increase in the red blood cell mass, the potential of the blood, the blood viscosity, right? And more cardiovascular stress on that inner wrapping of the arteries, right? That endothelial baby endothelial tissue that I will tell you is your lifeline between your heart, your kidneys, and your brain, okay, through the carotid arteries and things. And when you look at too much, even a little too much testosterone, most men don't need 200 milligrams a week of testosterone unless you're like doing it for just the gym only, which again, it is what it is. And I don't take that much. I like the 0.5. I like 100 every 5 days. But I'm in a point in my life where I got my muscle. I want to hold on to it, and I want to hold on equally to my brain and my heart and my kidney function because I'm in my 60s. And you don't need much, guys. Even back in the day, I've taken care of some of these big guys, the real VIP guys in the 70s and 80s, bodybuilding, powerlifting, strongman. And I was always amazed. Some of these guys, they don't take that much. That's why some of these guys actually lived normal lives to their 70s, even 80s, right? And it's true, right? So, I mean, not a big fan of Arnold Schwarzenegger these days for all the stuff that he does and doesn't do to protect men on steroids, but he's still alive, and he's what, 80 now? I mean, Stallone's 80. I mean, they did steroids, and they're alive and kicking. Okay. So next thing is the reproductive side, where you're a younger man, maybe in your 20s even, or 30s or 40s, even 50s and up. And who wants their testicles to be atrophied? So it's definitely, there's going to be a dose-dependent phenomenon to a degree on testosterone shutting down your hypothalamus pituitary gonads. However, when you hit that threshold that is very low threshold, I don't care if it's gel, if it's oral undecanoate, or if it's pellets, even nasal gel, and any kind of regimen of injecting testosterone, if you really understand this stuff, you'll see that the LH and FSH is diminished very easily, very, very easily and very quickly. But it's true that your testicles, to different degrees, depending on who you are, will atrophy, and that's annoying. And it's very, very bad. It's not deadly, right? It doesn't cause, with the grace of God, testosterone doesn't cause testicular cancer, or even prostate cancer. Doesn't mean you don't look at the prostate and the testicles, but if you're young and you want to have children, you're going to be in a tough bind. Anyone that tells you, hey, just take testosterone and HCG and with or without enclomiphene or clomiphene doesn't, if they say that to you and it's that easy like this, they're doing you a disservice. They're not experienced healthcare provider in providing androgens, because it can work, but we can't say it's going to work forever. Matter of fact, when you run testosterone and HCG, for an example, which is the classic, and I provide it to all my patients that want it, that combination, you don't start adding gonadorelin, gonal F, and clomiphene or enclomiphene to HCG. That is, you know what I call that? That's a big fat mess. That's a big fat mess. You can do testosterone from the beginning of a natural guy who's on testosterone. Doc, how do we start? But I want to kind of keep my testicles non-atrophied and potentially run the hedge and provide myself with not being shut down so much, but I understand that I could be, doctor. And then there's some data on this. If you start these men, they're not steroid using bodybuilders. They're just regular guys, but they were young in their 20s to 30s. It wasn't a randomized double blinded. It was just it was just an observational study. But it's interesting that within 1 year after starting testosterone with different doses of human chorionic gonadotropin, that they maintained what was seen as normal sperm count. But after a year, I'm talking, okay, 1 year, great, good for you. And how many guys could keep doing the injections? Most guys, they can't keep up with it because it's just a ton of injections. And if you're traveling, you have to reconstitute this and put it in freezer bags. I'm on the plane. Hey, honey, can you just put this in the freezer? Or here's my freezer bag. I mean, running through TSA, you can, but it's just once you open that up and you mix it, most guys won't. I'm going to go on vacation. I won't do the HCG for a week or two. I come back. I'm going to miss a few. And that's what happens. And then it's like, doc, do I need to be on HCG? Sir, you can do whatever you want. But I thought you wanted to be religious on this and try to, and then after years, no one does it straight. I know there's probably 5 guys out there. I did it straight for years. Okay. I'd love to hear from you. But did you check your sperm count? And I know guys there are studs out there, studs. These guys can be on almost any steroid and they're still having children. Whenever we hear that kind of in my practice, we always, myself and my managers and my nurse, we look at each other, we go, is that his kid? LOL. I'm just telling you, it only takes one, but when you're shut down, you're shut down. I spend my whole day in getting men that are even just 35, 45, they're on testosterone, not steroid guys, and then I have to give them regimens without testosterone. That's going to be HCG with different degrees of N-clomiphene or clomiphene, and even now we're hedging into HCG and gonal F, which is really incredible, right? That's really the best one. It's really an HCG mimicker, LH analog, and then an FSH analog. And again, the fertility guys know what they're doing. These guys know what they're doing, and I just mimic that. But then this is a whole mess. That how deep are you? How atrophied are testicles? Do these guys have different testicular abnormalities with cysts? I'm not cancer. I see everything. There's something called varicoceles. This is the urology brothers. So again, I could talk for that forever, but it's so many men, they're on so much and they're just like, man, I didn't want all that, the bloat, the acne, the oil skin, irritability, and mood. I mean, anxiety, forget depression, waxing and waning, and mood disorders. I think the number one side effect for so many men that even go on a little bit of testosterone, not to mention with the inostrozole, you can just Google that and fact check that with or without my videos and the millions of comments. This is a recipe for disaster for a man that has any anxiety. But hold on. If you have anxiety and you have low testosterone, but do you really have low testosterone? Or you're taking testosterone and it makes you feel good and it helped with anxiety or depression, good for you. Good for you. I do it all day long for guys. But there is going to be a point where you're going to be like, that is too much. And now my mood is bad, my irritability, forget the side effects of gynecomastia and acne and hair loss. Who even cares? I mean, we go for the real important things, like the anxiety, the mood disorders, the suffering, the danger in that from a mood, from a psychiatric standpoint. And then, of course, the blood pressure and the cardiac and the blood clots, potentially. It's rare, guys, but it does happen. What's your fingerprint? And then it's like, what are we doing to back off the fertility? This guy's 30-something. He wants another kid. That woman's going to leave him. Guys, this is real stuff. And they're nervous and they're just a wreck because this woman they're having fights now because she's not one of the gym girls. And I'm not putting down the gym girls, even those girls, but they're done with children or they don't want children. And they're with guys, dating guys that are on steroids and testosterone. And they're in the world. They're in the group. And they're not going to have a fight about that. But real men that are on testosterone, not to mention steroids, they're in relationships with younger women that don't know what this is about, or now they like how you look and they love your sexiness and your muscles, and now you can't produce a child with her. I've seen at least 1 or 2 suicides over this. I've seen devastation and divorces. Okay, I'm like the scare guy, right? So why clinics end up prescribing more and more drugs? Because they think guys want it. and I know guys do, is that you pick your poison. One medication creates another. It's called polypharmacy, a drug for a drug. So you end up walking out of these clinics with testosterone, aromatase inhibitors, HCG, SERMs, and then they start blood donating. And now, and I'm humbled that a lot of these places are copying me, and that's humbling for me. And they're giving you telmisartan, maybe nebivolol. I mean, do they know what a PCSK9? Where's my PCSK9? This is so expensive. I get it through the insurance companies for my patients because I don't know. I kind of know how to do it, right? And the guys who need it, that's $500 a month, Repatha, or 400 to 500. So the next thing is you should look at your testosterone and take a small dose. Microdosing is great, but can a guy take testosterone every damn day, every other day? That gets old. For a newbie, it's like a new toy. It's going to get old. In the end of the day, you need a sustainable dose. You have to look at, like 100 milligrams every 5 days. I'm going to say it for the millionth time. If you just need to take it every week, every 7 days or less, that's fine. A lot of guys do great with twice a week. 7 divided by 2 is 3.5. So you're not going to split one day, 12 hours, 1 in the morning, 1 at night. Some guys do, but they don't usually last on that. But some guys are very OCD like me, and they're very on point, and they love it, and they just live for this. And that's awesome. Most guys, they'll inject on a 3-4 every 3-4, 3-4, 3-4. It's okay. And then again, some guys need to inject Monday, Wednesday, and Friday, or every other day, odd days or even days, or to remember it. And some guys just, again, they'll just do like me. I do the 0.5 milliliter of cypionate dosed at 200 milligrams per mil. And I love that dose every 5 days. Sometimes I look at my counter, I go, wow, it's day 6 or 7. I've probably gone day 8 or 9, but it's on my mind all the time. And I'm at that point, you kind of do feel it. It's amazing. This is fingerprint. You feel it kind of diminishing, right? You're tired, or your sex drive, or maybe you're irritable. And the irritability can be from too much when it's peaking. How many guys on day 1 or 2 from that bolus, right? Then if you look at your labs, it could say up to 2,000 or 3,000. I mean, within 24 to, it just does. Everyone's got different kinetics. So the goal is this, guys: lowest effective dose, individualized treatment, careful follow-up, lab monitoring, cardiovascular risk reduction. I say it for the millionth time. I'm never going to stop because all I'm doing now is cardio, kidney, metabolic, right? Go to the Google, go to your AI, cardiovascular, kidney, metabolic. One more time, cardiovascular, kidney, metabolic. Just put it in, and you're going to see that's a continuum with my ABCs. That's glycemic control, diabetes and prediabetes, of course, glycemic control, A1C, glucose and A1C, blood pressure, kidney, cardiovascular disease, understanding, do you have cardiovascular disease? Can you look in your arteries, guys? Look at this. Can you look in the artery? Hold on. Can you look in your arteries? There's a beautiful artery. And then over time, it turned, and it's true, guys. And that's what you want to take. This is my day job, right? This is what I love. I'm so bored of testosterone. I'm just bored of it. But what I'm not bored of is the methodologies and my education to prevent heart disease on every one of you. Because we have so much technology now in diagnosing with calcium scores and even CT. Look at Clearly, Cleerly, Clearly Heart. You can, if you want to, and if you're not, if you have no heart risk factors at all, you're super healthy, you shouldn't do this. But I don't know, if you're over 40, maybe even if you're really healthy, you still can have plaque in the artery based on your genetics. Maybe you're just a really hard driving guy, and that stress can just cause heart. There's a lot of there's a lot of pieces to this. This is my life. A1C, blood pressure, cholesterol, abnormalities in cholesterol. I know it's not just cholesterol, but you don't believe the misinformation that if once you have heart disease, if you have any plaque in the artery on a calcium score or a CT angio with plaque analysis, right? Enabled plaque analysis now. Welcome to the new world. What the soft plaque is where the money is. And you could look at that on special metrics, but it's expensive. And What are you going to do with the information when you see you have soft plaque, but you have no calcified plaque? Calcium score is 0? Because that takes decades. That could take, well, years, maybe 2 decades. It really can. The soft plaque starts. And once you have soft plaque, I can tell you, you're damned to get rid of it. Now you want to stabilize and harden it. But this is my life. And how do you do that? A, B, C. Okay. So with too much testosterone, and you're going to think, oh, doc, you're wrong. The Travers trial showed that testosterone is safe. Bullshit. It's just the Travers trial were men that had heart disease, and they weren't young. They already had heart disease or high risk for heart disease, and they had legitimate low testosterone. Again, not guys in the clinics where you don't have really low testosterone. These had really low testosterone, and they were heart disease patients. They had low T. They randomized, double-blinded, and they ran it forward. And the treatment arm got gel, androgel, and the other arm got a placebo gel. That's not injections of testosterone. And they only brought their testosterone to like 400 or maybe a little more than 400. That's not what we're talking about with injections of testosterone, and that's small print. And every man in both the treatment arm and the placebo arm, they were aggressively managed for diabetes, blood pressure, and cholesterol. So I was expecting it to be a neutral event, just in the end, where the treatment arm statistically had no more poor outcomes in events, cardiovascular events. They already had a cardiovascular event. I mean, this is a first of its kind. But again, if you're taking that information on men that have heart disease, that are protected on medications for heart disease, diabetes, A1C, blood pressure medicines, many medicines after a stent or heart attack. I mean, it's just sad. And then tons of cholesterol medicines. Again, and then they gave him some testosterone, not much, for 2 years. And the treatment group versus the placebo group, there was no difference in having a secondary event, which is a heart attack or stroke or death. It's interesting. And then they had side effects of AFib and acute renal injury and some blood clots potentially. And I don't think those met clinical significant values. So I'm not going to poo-poo it, but it just doesn't make sense. Right. So again, this is the Travers trial. So if you think, oh, I'm just going to rely on the Travers trial, it's wrong. It's an apple to an orange. It's an apple. Well, if you want to look at the Travers trial, you should hammer down your A1C, your blood pressure, and your cholesterol. This is what I do. This is what I do. I want you guys to do it. What are you going to do, guys? If you're on too much testosterone, don't panic. No need to panic. Work with an experienced physician. I do have healthcare providers that I'm training. They're on a directory. Reassess your symptoms. Get on the health portal. Do it yourself as much as you can. Understand your labs. Reduce the testosterone down to something like 100, 120 a week, maybe 160. Easy as she goes. Watch your blood pressure, your cholesterol. Understand, get a calcium score, and look at the red blood cells. And you can't look at those red blood cells with just a CBC. You need to, it's mandatory you have to look at iron studies with ferritin and transferrin fat. Most of you guys, it's transferrin fat saturation, otherwise known as iron saturation, total iron. There's a TIBC. Again, there's different labs have different, they call things a little different, but they're iron studies, including ferritin. And if you see that your ferritin is low, that happens to a lot of guys, that's just because you're using the storage of iron, which is ferritin, to make the red blood cells. You see, this is, guys, it all makes sense, but this is androgen-induced erythrocytosis. Again, when you're a specialist like me, it's kind of annoying that the doctors don't know. You guys never annoy me, but the healthcare providers do. And the gurus in the streets and all these influencers, they copy all this stuff, which is fine. It's fine. Okay. And they learn the stuff themselves. They read all this stuff. And it's just, they just tell you these simple, do this and do that. It's not simple. It's not simple. And if you're young, you can do almost anything. Young guys could drink, do coke, drugs all night long, shower up, shave, spread some deodorant on and go to work. You get older, your health reserve is taking a hit. Again, I am a Testosterone doc for a reason. I'm going to close up with this. I'm going to answer questions. The goal isn't to have the highest testosterone in the room, unless you're a big bencher in the rooms and this. And those are young men, and I love these guys, but man, that's a tough deal. Goal is to have the healthiest heart, the healthiest brain. How about the healthiest erections? And the irony is, all that testosterone, probably in the beginning, phenomenal for sex. Then you're shut down, and guys come to me, and I have to hit a reset button and figure everything out. So, all right. So, blood vessels, you want to live, here's the truth, with the grace of God and the technology and being careful and understanding how you integrate diet, exercise, behavior, supplements, and some agent medicines that are brilliant that you need, like Repatha. It's down there. That's all I want to say. And the accuracy is, we know now that super physiologic doses of testosterone will increase blood pressure. It does have adverse effects on the lipid panel that could lead to downstream effects of heart attack and stroke, and in susceptible individuals that have disease underneath. And that's why we see bodybuilders and the steroid users, they don't die from prostate cancer with the grace of God. They don't die from brain cancer. Lyle Alzado, I don't know what really happened to him, but he said he did steroids and he had brain cancer. Oh man, what a beast this guy was. But this is you could fact check this guy. Anabolic steroids and testosterone don't cause brain cancer. They don't even cause prostate cancer. Thank God. Otherwise, I'd be dead. Schwarzenegger's dead. Stallone's dead. A whole host of us are dead. And I'm not saying if you have prostate cancer, for crying out loud, its potential when you're on can accelerate it depending on what stage of prostate cancer you have. And that's urology stuff. And the next thing is, testosterone absolutely suppresses the hypothalamus pituitary gonadal axis. And again, it's a dose-dependent phenomenon to a degree that if you take a guy who does a lot of testosterone for a long time, he's more suppressed than the guy who's done a little bit. It's just, he's down deeper. And I have experienced this because I've been doing this for over 20 years. So, and can you take HCG to preserve that intratesticular access? Yes, you can. But listen to this. I'm going to close on this and take questions. This is something that a patient brought to me. I have some bro science guys. I love them. They're brilliant. And I've learned from them. So they said, Doc, these clinics are giving testosterone and they're giving HCG to preserve your hypothalamus pituitary gonadal axis. But hold on a minute. HCG is a luteinizing hormone analog, and it's just stimulating your Leydig cells to produce intratesticular endogenous testosterone, which will spill over and increase the serotonin, and then you'll get the milieu in the testicle from this medication that stimulates that pathway inside the testicle, and then you bubble up and you produce natural testosterone to some degree, despite the brain being shut off with LH. But you're bypassing the brain. So here's the fact, and we have science on this and a lot of anecdotal evidence. It will work. It's a game, but there's downregulation on that testicle. And I could tell you that your brain is the power. That's the main piece. So when you're taking steroids or even a little testosterone, depending on how young you are, old you are, your fingerprint, your genetics, your testicles, oh my Lord, guys, chemical sensitivity, the whole kit and caboodle. Your brain, even though you're hitting your testicles with these medications, your brain is shut down. And that's where the bottom line is, you see? You're getting shut down from the exogenous testosterone that's circulating around your body and going into your central nervous system. I'm telling you. And depending on who you are, you're just playing games. And then we're just going to give enclomiphene or clomiphene at the same time. That is horrible misinformation, because it will work on paper, But most guys feel terrible because the SERM, the selective estrogen receptor modulator, and clomiphene or clomiphene. One is right hand, one is, they're racemic, they're isomers, right versus left, guys. That's the difference of them. And there are different, as far as the receptor targets and the physiology, there are differences because of right, left hand isomer. It's stereoisomerism. You can ask chemists and pharmacists, they'll tell you. However, if you think it's a miracle and then you're going to do this and your numbers look great on paper, including your LH and FSH, it makes me so angry because it's such bullshit, because it looks good on paper. But when you block, you know the mechanism, you're using that drug, the SERMs, not SARMs, SERMs. You're using that drug. Fact check what the mechanism is of clomiphene. Check it out. You're using it. This is old news. It's annoying. You're using it because you're playing a game. You're blocking the central nervous system, limbic system above the pituitary gland. Shout out to the neuroanatomy guys. And you're blocking estrogenic receptors. And that downstream effect in the central nervous system sends a message that something's wrong and we need to produce more testosterone. So it sends the GnRH goes up, and then you get this effect, and it's not natural and pulsatile like your real circadian rhythm. And I'm telling you guys, this is true. But your pituitary is a firing station, and it will send out LH and FSH. So if you look at it on paper, oh wow, it's up, down. And then the drugs. So you're playing a game on paper, and you could, some wise guy, that you're looking good on paper. That's just like an embarrassment. How do you feel? Oh man, I'm moody, I'm depressed, I'm really irritable. Erections are bad. Shut it down, guys. Try to go less and stabilize it, or don't even take testosterone. Get off and lose weight and get in great shape and keep your natural testosterone on board as long as you can. I'm done. All right, hope you guys like that. It's kind of the same old speak every time, right? But that's what I'm doing. Let's get some questions. I've been on 500 milligrams Cypionate a week as I want to blast, test again, muscle quicker. What to look for safety? Wow, brother. All right, so 500 milligrams of test. How old are you? I just want more information. So that's going to build, right? That's a steroid dose. Back in the day, a lot of guys truly lived on Sustanon 250. They maxed out their gains. Sustanon 250, so. Again, when you want to look for, you're going to do that. You're not alone. So it's going to work. You can be strong as shit, right? It's going to be unbelievable. And with that kind of testosterone plus or other different steroids on top, with, the Masteron, the Primobolan, the Decadrabolin, the Equipoise, the Tren. Come on, let me keep going. The Anavar, the Anadrol, the Dianabol. I can go on and on, right? There's like 20 steroids, right? And forget the SARMs and the growth secretagogues. When you're on real steroids, I just think growth hormone is not a joke. The real guys, what do the real guys use? Real steroids, they add steroids and growth. And then there's insulin and all this kind of stuff, and that works. But man, you're going to pay the piper. And when you're young, typically, with the grace of God, nothing happens because you have tons of health reserve. Sir, do your H&P, do a history, get your history done. Understand, just look at your A1C. I'm assuming you're not diabetic or pre-diabetic. So for you, it would be blood pressure, the cholesterol, get a calcium score. But if you're under 30, the calcium score most likely is not going to help you because it's going to be 0. He's 26. There he goes, young guy. So the calcium score is useless. Because it's going to give you a false sense of security. Because I'm 26, I'm on steroids, calcium score is 0. Dude, your calcium score better be 0. Even after doing Tren and steroids for years, it still is going to be 0. Unless you have horrible genetics, family history, and then you shouldn't do this amount of steroids. All right, blood pressure control, understand, and not just taking Telmisar and Nebivolol. I have indapamide now. Check out indapamide. Because I'm a research level guy, right? I look at, and now with me with real AI, and I use open evidence, not open AI. I use open evidence because they give it to doctors that have an active medical license. And this is freakish. It blows It blows Claude, it blows chat it blows it out of the water because it's focusing just on the medical data. And those are good too. I compare them. But when I look at it from my level of asking it questions, really complex internal medicine questions where I put things against each other, it's just, woo, I'm like a kid in the candy shop. So you want to watch the blood pressure, brother. You want to, what are your goals, right? So you do it, you're going to do it. I don't know, try to come down to the cruise. I'm assuming that you're never going to come off, right? Once you expose that to your brain and you're loving it, I mean, I guess if you're going to do it for 2 or 3 months and then come off, you're going to feel like shit, and then you're going to lose the gains. You're going to lose the gains. Come on, guys. And you don't even want to go to the gym. This is where back in the 70s and 80s, man, I saw this, and it was just like, shit. And then so you just stay on. Here we are. So blood pressure, you can get the baseline echocardiogram. If you're big and you've had LVH, family history is huge. I wish I could do it for you, and tell you exactly what to do and what to look out for, but you got to do A, B, C, Ds. It's on the damn health portal. You can do it yourself on there, but really keep it to a limited time. You could definitely look at your blood pressure. Try to, if you're on that kind of drug level, try to keep the sodium chloride down. Don't listen to the vertical diet guy. This guy's a sham. You're going to be hypertensive as a banshee, and that's just ridiculous. I can't support any misinformation anymore. It's just an embarrassment, guys. I don't care who I piss off. I'm just tired of it. You have to understand, if you're hypertensive, sodium chloride is going to worsen it. I don't know where these guys come up with sodium chloride is not, we need sodium chloride. Oh, and your heart's enlarging, and what are your risks? Look at me, Mom. I'm in my 60s, but on steroids on and off since my 20s. Why? Because I was an internist, right? And I still am. And I saw the guys dying from heart disease. And I made up the ABCDs, but I didn't call it the ABCDs until probably a couple of years ago to organize it. And for you guys, most of the steroid guys like you, young, just keep the doses down. Don't do it. Stay on testosterone, just a dose that is, like less than 200 a week typically, and kill it. And with or without HCG, and you're going to want to have kids probably, right? So I just spoke about that, what you can do about that, right? You're going to take HCG and clomiphene once you come off it, and you're going to have that window where she's going to ovulate. And come on, guys, it's simple, but you're going to have to do something on it. And hopefully you're with a girl that's going to be cool about it, right? And it usually is going to work because you're young. I'm rambling because I have so much information to give a guy like you. Just don't do that much. 500, I don't know. You're going to do it. You're going to stay on it. I guess back in the day, we would do it. I don't know. We would really do blast like that, 6 weeks or 8 weeks. As much as you love to keep going, you got to come down, and you're going to not come down and come off. I hope you would with PCT and all this crap. But if you don't, at least bring it down to a TRT dose. Oh my God, guys, 400 a week is not a TRT dose. I love you guys. How much you on, Doc? Well, I'm on TRT, Doc. Well, what is TRT? Oh, I'm on 400 Cipinate, man. How long? A couple of years, on and off, blasting up and this and that. I feel great, Doc. I just I don't want to have a heart attack. Please help me. And I'm like, 400 milligrams? That's not TRT. But I love you guys. It is what it is. Next question. Be careful, sir. Blood pressure, heart. Should you attempt to maintain total testosterone E2 ratio, or should you maintain that E2 ratio thing is ridiculous? A natural would, great question. Ratios are ridiculous because here's the embarrassment on that. Anyone who tells you that to you is a buffoon, because the number you're looking at will vary within hours of the depending on what your injection, and when you go to the lab, your E2 and testosterone that's it. It's ridiculous. When you're on exogenous testosterone injections, this is a moving target. Is it 24 hours after the injection? Is it total? That's only, so you're right. So that, because the target is such a huge variability, you're talking where if you're on, like, say you're on 150 a week, not 200. Say you're on 120 a week and you feel great. 0.3 twice a week, dude, of cypionate dosed at, its concentration is 200 per mil, like my average patient, right? And then once you're at steady state after about 6 weeks, and then you go to the doc, I went to the lab. I had no time. I couldn't go to the lab at the nadir, at the low point. I had to go to the lab because I was busy and I have work, and I had to go to the lab that morning for, all my labs, for my cholesterol, right? My kidney, my cystatin C, all my stuff, urinalysis, protein in the urine. I'm looking at all this stuff now for all my patients, and of the red blood cells, and I do it all for them, right? The erythrocytosis, and I throw testosterone in there. And the guy goes, "Doc, I'm so sorry. Guys, testosterone could be like greater than 1,500. It could be 1,200. And then the free can be like double or triple the upper limit normal of what the free testosterone is." And if you're using the metric for ultra sensitive estradiol, that's going to be off the chart too. And that can go up to like 29. It can go up to 40, 50. There's multiple. I work all over the world, right? So is it a millimoles? Is it a picogram per milliliter? Again, America is the standard picogram per milliliter. And when you look at that, if it's 1 or 2 days after the injection, it's that estrogen testosterone ratio. It's going to be ridiculous. And then if you just give it a few more days, it's logarithmically different. How the hell are you going to make sense of that to do anything with any kind of semblance of science and clinical judgment? You're not. So you go by feel. You go by how do you feel? You look at the testosterone at nadir. How do you feel? Are you bloated? Are you puffy? How's your? I'm telling you, this is not why these clinics can't do it, unless it's concierge level like me. I'm just being honest. How the hell do you do it? I always ask for decades. How the hell do these guys do it? They must be calling up. They're anxious and they're short fused, and the acne and the bitch tits, and the estrogen's crushed, and now estrogen's too up. It's too high. I just have to get crazy like this because it's a conundrum to me. It's just an absolute sham what's going on. I'm sorry. You have to do it yourself the best you can. There's some healthcare providers, easy as she goes. They agree with me. I'm the boss. So easy as she goes. You look at that estradiol at a low number, and estrogen is great for men. I don't touch my estrogen. I stopped that 20 years ago. Aromatase inhibitors, be careful with those. Show me the data. I'm a data guy. I'm annoying like a lawyer. Where's the data? Where is it? We don't use data. We don't need data. Well, in my world, we like data. So there's no data. Let's go with anecdotes. Well, no one has more than me. Microdose. Go by feel. You're puffy and bloated. Lose weight. Cut the sodium. Don't listen to the vertical guy. Cut down the calories, carbohydrates. Train your ass off. Use GLPs, GIPs. You want retatrutide? Go for it. I'm not recommending it for you. I'm not your doctor. Stay lean and mean, dude. ABCDs. And you want to cut your estrogen down? Take less testosterone. I call it the tax. You don't want to pay taxes? My accountant told me years ago. I said, "Sir, Steve. I don't want to pay these taxes. I want more deductions." He said, all right. Well, doc, we're going to look at your deductions. You got complicated stuff going on. Stop making money. I don't make that much money. Stop making money. I went, ooh, I could use this in my medical practice. You don't like that estrogen? Proportional to the free testosterone. And when you go, is it 2 days after the injection or 5 days or 3 days? When are you doing it? If you're microdosing, this is going to be all over the place. Most guys that are tightly microdosing every day or every other day, unless you're doing baby doses, knowing your fingerprint, I'm talking less than 0.1 mils, 0.08. I do it all day long. I have to do this all day. And if they really like that every day, if you can do that, which good, I can't do it. I don't have the time for it. Who does this? But I let guys do it because it's not liability to me. But they just most guys can't keep up with it. And the guys that do this incredible, arcane, just obsessive microdosing, they do it because they have to. And they do it because most of it is anxiety. Okay? They can't take these ups and downs. Okay, next question. So good question, sir. I like to go to town on this stuff. I am on day 12 of Cypionate, microdosing 20 a day, 20 milligrams a day, 140 a week as prescribed. They had me doing 70 every 3, but I was feeling trough lows. Okay, sir, there you go. Love your opinion. Sir, you're the guy. I just said it before your thing came up, right? So you're doing it every day, but hold on, 12 days? Okay, so you have to give it for steady state. You're not going to have to wait 6 weeks. But theoretically for the kinetics, because you're at steady state, now you're making a change. So you have to wait. Depends on your fingerprint. A man like you, I would wait about 30 days to let the old regimen wash out. And then the most important thing is, how do you feel? You see that? You see what this guy just proved to us? And I didn't see that question. He proves to us that men are doing it because he's feeling something. So most men don't feel, even now, if you're doing it every 2 weeks, that is like, oh my God, those doctors that give one injection every 2 weeks. This is why these guys, the real doctor that I really love, and they're endocrinology, they're good for diabetes. They work in hospitals. Someone you love, they're going to help someone you love. You're going to love them. If a surgeon saves someone you love in the hospital, they're not influencers. Hey, what's going on? If they are, you got to question that. I'm just kidding. I mean, I became an influencer over the course of in between patients. Hey guys, what's going on? Here I am now, right? I don't go to the hospital. This is my job. I've transitioned very slowly and steadily, and I still have some patients. But when you look at this, and doctors give that one injection of 200 every 2 weeks because the textbook says that from 1950, doctor. And that's why it's embarrassing for him and all the anti-aging places are out there. But the anti-aging places, they're just giving too much. And again, most of these places don't have highly qualified providers. I'm sorry. It's true. But you're getting your drugs somewhere. Good for you. So the accessibility issue in America has been solved. Here we are. Let's not mess it up, guys. I hope they don't close down and shut down tele-TRT because it's good for you guys. But now take care of yourself. So, sir, you're microdosing 12 days. Give it about a month. Here's a secret. The longer you can give it, say you give it, doc, the guy, my patients know me, they go, doc, let's make a change. Let's go with the change, doc, because I want to really fine tune. I'm watching the ABCDs, right? These are my patients. And he goes, well, let's just tweak it a little bit. But you're right, doc. Let's give it like 2 or 3 months, because what happens in 2 or 3 weeks or a month is coincidental. And then you're all over the place. You're back, you're up, you're down. You see, this is someone who's been doing this for over 20 years now for patients. I've been doing it myself about 35. So I'm from the streets. So you're microdosing, don't jump stick with it at least a month. Don't just live and die by that number. Go by how you feel. You see? That you don't have the trough and the low. Is the low irritability and anxiety or depression or poor sex or concentration? Dude, you have more going on in that brain than just testosterone. But testosterone, that stimulation on your brain, it's all the animal brain. The dopamine, the norepinephrine. I'm not a psychiatrist. I work from the chin down. I'm an internist. I'm good for not having a heart attack or kidney disease or a stroke or a blood clot. That's all I'm good for. That's enough. And the psychiatric stuff, you got to go by feel. I let guys go by feel, but they don't want to take too much. But I give guys different doses based on their fingerprint, how they feel, and then I keep their ABCDs perfect. You need to do it yourself now. I'm out there to help you guys do it with all these metrics on the health portal. Next question, sir, give it time. I've been prescribed 100 milligrams Cypionate a week. Free test is 1,100. I think I'm going to increase test 2 milligrams. So not the free test. That has to be the total test, and that's nanograms per deciliter. I'm going to increase to 200. How can I look after myself? So you're on 100 a week, which is, that's not obviously that it could be a little low for guys. I like 100 for most of my guys. Everyone's got fingerprints. My average bear, including this bear, I take 100 of Cypionate every 5 days. Again, the kinetics on this, guys, are all fingerprint oriented, but you're doing it every 7 days. That's a little, some guys can do that. That might be a little low. Imagine I'm saying that. So maybe take the 100 every 5 days. Now you're saying your free test, you're not, it's not your free test. That's your total test, but that's okay. You're going to see the free test is a whole nother, it's a whole nother, probably on your scale, 155 or 25, right? They're all picogram they're picogram per milliliter versus nanogram per deciliter on the total. Again, guys, look at it. So how would you look after yourself? ABCDs. Just watch your blood pressure. How do you feel? You always go by feel. I take the steroids. I feel great. I don't feel great. Well, then don't do that. It's your body. There are men are different. Now, let me just digress for 2 seconds here. I took care of the top steroid users in the world, right? I don't really do that anymore for the harm reduction. I take care of just regular guys because it's not, I mean, it was tough because these are young men that come to me, they trust me, and they're looking for a blessing on taking a shit ton of steroids. And I just can't do that. So I do harm reduction. I try to give them lower doses and I try to do it, but they're like, Doc, you're not giving me any steroids. I'm giving all these steroids to myself. Please help me not have a heart attack. And that's what I do. I'm not losing my license for treating your blood pressure, for checking your calcium score, and for modulating and for prescribing you Repatha, which is disgusting that doctors don't even know what this is and freaking prescribe it. I'm cutting tough now. I'm disassociated with all the big organizations. I'm here for you. I'm a free guy now. I'm standing alone now, guys. I don't need them anymore. I'm a free guy. Watch out. So use these meds. Use anything in the kitchen sink to stay alive and to kill, to just stay alive and just kill forever. Because I'm just telling you, that's what it's about. And you're getting older, you're going to suffer with or without testosterone. Thank you. Sorry, guys. I get emotional. So, sir, you want to check your ABCDs. Again, blood pressure, your heart. If you're over the age of 30 or 40, 30 to 40, and if you have any family history at all or no family history, you want to get a calcium score. And if you have any plaque in the artery, it's a wake-up sign how much plaque. It's either zero plaque, a little plaque, moderate, or high. It's very simple. You can look at my videos on the health portal. It's so simple. And then you put together a regimen to stabilize that plaque like I've done. I had heart disease in my 30s and I'm in my 60s. I've even regressed some of my plaque. I've delipified, but that's kind of very arcane and complex. I've stabilized because I've done CT angiograms. I'm still alive because I did steroids. I did it. I was a real guy. And I'm on testosterone. I'm not bullshitting you guys. So it accelerated heart disease, 2 types, coronary artery disease, number 1 cause of death, and then heart failure. Now we have, check this out. We have heart failure with preserved ejection fraction. Steroid users are absolutely at risk for this because the ejection fraction is still fine, but they have problems with the enlarged heart, LVH, and the thickened walls. Even without thickened walls, you're having problems with relaxing the heart. Systole is the squeeze, that's ejection fraction. Your heart needs to relax properly. Fact check this, diastolic dysfunction. Anabolic steroids, absolutely super physiologic doses, not testosterone. We have tons of data on this. And I've seen the suffering in my arms with men that have died and from suicides and depression, because once you're cachectic and your heart is you're bloated, your ankles are swollen and you're in heart failure and you're even 40 or 50 or younger because you have just had bad luck and you get steroids and your blood pressure. I could list off a ton of bodybuilders. Okay, guys, it's not misinformation. It's true. It's just gambling. Men are guys like us. We take risks. And when you're young, you could absorb anything. But I don't want you to do that. It's health reserve you're chewing into. You don't need it. But if you want to be a pro or on a power lifter, on the strongman level, or bodybuilding, I have a lot of respect for you. You're, like pro race car drivers. I mean, I know some of these guys. It's what they do. There's risk. I'm trying to soften that risk. So let's keep going. Next question, guys. Tough questions, man, because I just want to protect you guys, but I know people are going to use steroids. Next question, Mark. If I'm 13, will there be a problem in the future if I use human growth? Oh, wow. 13-year-old guy, buddy. Thank you so much for coming on, young man, young guy, So IGF, I'm not a pediatric expert, and this is a good question. So, and will I have withdrawal? So secretagogues, growth hormone, IGF. I don't think so. I'm not an expert on this. What about other peptides? You got to be careful, man. Let me give some I can't answer that question really because I just don't want to say, no, you won't, son, or you will. I mean, anabolic steroids, let me talk about what I know. Anabolic steroids have a condition called, and I want you to fact check this, anabolic steroid induced hypogonadism. One more time, anabolic steroid induced hypogonadism. So anabolic steroids absolutely at a certain point shut you down from the brain and your testicles, disconnected, and you withdraw. There's a withdrawal, and it could be deadly with suicide and depression and quality of life. So guys have to stay on testosterone like me for 35 plus years and counting. So that's androgens. When it comes to secretagogues, which are weaker, right? Because they're stimulatory to the pituitary for the growth hormone. They're just they work and they could be okay, for I think adults that need it. Again, it's true. I mean, they have some effect, positive effects, and growth hormone can be awesome too. I just don't know about living on it long term when you're an adult because I don't like that word growth with IGF when I talk to cancer doctors because at my age, I'm trying to skirt cancer, skin cancer. Look at the skin, right? I'm an Irish guy, right? This is like we got a new whole system here and we got to figure out the colors and everything. But I am red. I'm Irish and I'm in South Florida. So don't put me down for being red. My blood pressure is perfect. Okay. This is just red skin. Please. So why are you so red, doctor? I'm an Irish guy in South Florida. Okay. So here's the deal. You're a young guy. You're so young. You shouldn't touch your endocrine system, young brother. And I've been doing consults for guys like you in the last year or so. I've done them years ago and and I don't want to see you young guys because I'm an adult specialist, right? I'm an internist. I'm not a pediatric or a family guy. I'm not designed for, you're a pediatric guy, right? You're an adolescent. You're just going into adolescence. So if you monkey with your endogenous brain system that produces not just growth hormone, but just isolated growth hormone, not androgens and other peptides. I understand it. I know what you're saying, but is it worth it? I mean, you're going to have to do a certain amount of it long enough to get some kind of a gains. It will work, but all the other peptides, what are they? Secretagogues? You're talking, and you're not talking the healing peptides, right? We're not, and PT-141 is a sexual peptide. All these, how do you think of, doctor, what do you think of peptides? Oh, it's like, what do you think about cars? There's different cars. Peptides are just general term for protein fragment. And these things are not all peptides, but most of them are classified as peptides, which can be just an outrageous, just a conundrum, just a spectrum of just so many different agents, right? And it's like, okay, great, good for you. Healing peptides, BPC 157, TB 500, great. I think it's great theoretically. Where are you going to get it from? And does it really work? I hope so. I mean, weight loss peptides. I mean, let's keep going and going. Secretagogues, right? CJC, right? I know I'm hitting you with, I know what you guys are taking. And they've been around for a while. And they will work to some degree, but then you're going to stack them together What's your brain? Are you going to withdraw and feel like shit, and you're going to hurt you could. A developing I'd love to ask a pediatric endocrinologist. I'm a specialist, okay? So I only believe specialists, okay? And the bro science guys, come on, man. I just got to say, come on. Stop selling your bullshit. Okay. Trying to get tall. Oh, you're trying to get taller. Wow. I see that. I don't know, dude. Checking the growth plates and all that. I've seen you guys coming in. The growth plate, you look at the growth plates, right, to see if they're but you're so young, there's no way. So but we all know in America, not to mention with people that are rich, the rich folk are getting their kids growth hormone to grow taller. And I'm not going to say names, but I mean, we have some kind of well-known celebrities in the world that have done that for their kids. Okay, no names mentioned. So, young brother, you want to be taller? I get it. Why don't you go see a very good doctor who's a pediatric endocrinologist and be honest and get evaluated and say, I want growth hormone. I want to be taller. They do it. They do it. So go to a good doctor. They are doing now. It's expensive. Get real growth hormone. I've seen patients of mine this year that have had their children on growth hormone from good doctors to make them taller. I didn't see this like it. It was just in the past for like dwarfism and short stature, and now it's like short stature is relative. And if you have the resources, maybe you can take some growth hormone. Apparently, if it's done properly, they do it for what, a year or two. I'm not a pediatric endocrinologist. Okay, so go see a pediatric endocrinologist. I always love to give good information. It's not advice. This is information. So you go see a pediatric endocrinologist and be honest and with your parents and just say, this is what I want to do, and get an assessment. Maybe we'll have you back on the show. That'll be really cool. And see what they say, and then you'll assess it. You'll get good information. Ask the doctor that's a pediatric endocrinology that gives growth hormone, okay? Not pediatric endocrinology that does diabetes, okay? When you ask that expert, if you could find that expert, which they're out there, but they're not on every street corner. It's not a walk-in clinic. When you find that, Google it. You'll find them in America. I'm assuming you're in America. Or even in Europe, they have them. I mean, they're all over the world. And then ask the question. Wait to see them. You probably can't see them in 1 week. It may take a few months. Just wait and see them and ask the question that you just asked me about the shutdown. And then maybe they'll do it for you, and ask them why they wouldn't do it for you. Ask about the bone plates. Ask them about androgens. Check your testosterone. Look at everything with your family history. Look at everything with your labs. Look at everything with a history, with your fingerprint. Not the fingerprint. I mean, your personal genes, health history. We're in a crazy time now with all this diagnostic. And don't get your body scanned. Just go to a very good doctor. If they're out there, I can't find them. I'm out there, but I take care of men that are adult men. I wouldn't take care of, I couldn't answer your questions. It's not appropriate for me. But I could direct you, go see a pediatric endocrinology, ask them the question, get all your information, and then if they don't do it for you, you're going to have to make a decision yourself. Because I know guys are doing it themselves, but you're not going to take garbage off the internet and like IGF itself and secretagogues. You're going to use real growth hormone. That's what they do to get a couple inches. I'm all for you, dude. But you got to be careful. And I want your parents involved. All right. From what I've seen, one of the manageable, from what I've seen, one of the least manageable cardiovascular side effects is the endothelial damage. Even then, it would be nebivolol. What would someone naturally low blood pressure with naturally low blood? So from what I've seen, the least manageable cardio. Well, it's one of the more easier manageable, actually, not the least. So the endothelial damage, you're in my turf now. So, and that's the inner wrapping of the artery, okay? From your damn brain right down to your toe. That's artery, inner wrapping. That's the health. That's the life of your arteries. They need to be healthy and supple and nitric oxide. They need to vasodilate, constrict, healthy blood vessels. And then when they get diseased, it's a multifactorial process of glycemic index. That's my A1C, pre-diabetes and diabetes. Next is blood pressure that cooks that and just pressurizes and destroys it. The next is called dyslipidemia. It's the C for cholesterol. And guys, stop with this misinformation. Cholesterol is normal. Your brain does need cholesterol. I want you to fact check this. Your brain makes all of its own cholesterol. When you block cholesterol from this right here, or statins even, which I agree, statins, I like to use them like a chef, but I don't dump in salt. That tastes like shit, but I use a little salt. So when you block the production of systemic cholesterol, let me tangent for a minute because I have to stop this bullshit misinformation. When you block your systemic production, it's from your liver with any of these mechanisms, PCSK9s, right? We know the gut, Zadia, bempedoic, very specialized, and then we have statins, right? And there's some other there's some other stuff out there for years, but those are what I just said are the big, statins, PCSK9s, bempedoic acid, Zadia. When you use those together, you significantly reduce the atherogenic component of the lipid component for dyslipidemia. Anyone who argues that, I'm going to punch in the face now because it's just an embarrassment. We have so much, it's an embarrassment. Now, when you look in your brain, your brain is lipid. It needs a lot of cholesterol. The systemic cholesterol doesn't cross the blood-brain barrier, guys. It makes itself. It makes its own lipid. And the medicines that you give, I've looked deep into this before I make this kind of statement years ago. It doesn't affect that. Now, blood pressure, cholesterol, diabetes, what we got to work on. That's what you work on. I'm walking proof. If you have heart disease, you better understand. If you have any heart disease on a calcium score or in your family history or on a CT angio with plaque analysis from Clearly or heart flow, listen to me, guys. You need to anchor down the hatches like I've done. And if you have all these these are just agents, kitchen sink agents. I mean, there's no side effects, but it's expensive as shit, right? But a good doctor can get your insurance to pay for it if you're the right candidate. If you need it, you put it together with other drugs. Unbelievable. So I would say the endothelial effects, I agree with you. That's tough stuff. Once it's damaged, you don't get it back. You don't get it back. So in the end of the day, Nebivolol, if you have low blood pressure or low heart rate, you can't use Nebivolol. This is the fingerprint stuff. This is why I'm a clinical guy, right? I'm like an artist guy. So like I understand these agents. They're like my tools and I'm a chef. These are my ingredients. These are my seasonings. I have pots and pans. I have a multi-million-dollar kitchen. I got great people working for me. That's what I do as a doctor. I'm a chef. I have my ingredients and I understand the plate. I'm making a plate just for you, not McDonald's. McDonald's McDonald's, and I'm not putting McDonald's down. I mean, like, I like McDonald's actually. I go there once in a while. Shh, don't tell anyone. Don't tell my doctor. But in the end, McDonald's has to be cookie cut. If you deviate from that, you lose your franchise license. Let's go, guys. So be careful with your blood pressure. And you could look at highly sensitive CRP. You could look at smoldering inflammation of your blood vessels. You could look at your glycemic index, A1C. I love fasting insulins now. My arm's twisted on that. I thought in the day, we don't need to look at that. If you're a type 2 diabetic or a type 1 diabetic, this is a whole other animal. We always have A1Cs and glycemic index. You could take insulin. You could take glucose tolerance tests for not just for pregnant women and for people that are pre-diabetic, but this is again endocrinology. This is for diabetes, and those guys, the endocrinology guys, I pay homage. They know diabetes. I know it really well too, but they know it better than me because that's all they do all day long. They don't know testosterone like me because this is all I do all day long. We are both internal medicine doctors. Okay, we're cut from the same cloth. So you understand the A for glycemic damage to the endothelial wrapping over time in years, and then blood pressure, it's cumulative. And then, of course, again, the dyslipidemia, which is having non-optimal cholesterol for you, depending on what's in your milieu and how much damage do you have in your arteries. I'm begging you guys to believe this because this is like I'm like a sermon guy. I feel like a sermon giver because it's like secrets, but it's true, but it's complicated. So do you understand that? Look in the calcium score, look in your arteries. The technology is getting better and better. Before something happens, you could see inside. And then you have to go A, B, C, D, and always diet and exercise. Diet, exercise, diet. But people hear it and they can't make changes because we're humans. Our mouth tells us to eat. This tongue, this palate, it's a devil, an angel and a devil. This is tough, right? We want to eat. Some people have this problem, right? More than others. So that's why we have the GLPs. We have to use the agents. I know you guys love retatrutide. Okay, it's going to be a multi-trillion-dollar drug. Don't you hate that? Next question. I just love this stuff. 75-year-old guy. I have a new finding aortic aneurysm, 4.2. Oh boy, in December, June, 4.3. Should I be on? Okay, sir. Now I have a lot of patients with this, and I'm an internist, so this is in my wheelhouse. Bottom line, sir, is you need to see a very good cardiologist. You definitely need to get assessed with a CT angiogram and a transthoracic echocardiogram. This has to make sense to you, and then you have to be on blood pressure medicines. And one of the medicines they're going to want is going to be metoprolol or nebivolol or atenolol. They're going to need a beta blocker. This is evidence-based medicine, and you can fact check that because you want to keep that tension on that, or not. This is not endothelial. This is the whole goddamn thick. There's adventitia. There's a 3-layer thick wall that is enlarged on you because it's over that 4. And with the grace of God, they found that. This is what I see. This is just regular people, just with congenital, getting older, and hypertension. You see that? And that's where the money is for you. So can you be on testosterone? Absolutely. You have to be on a decent low dose of testosterone that doesn't affect your blood pressure. Voila. This is the best question of the night because I deal with this. I have, I don't know, right now, probably 50 patients that have yours or higher, 3.8, 3.9, always found incidentally on a calcium score or a CT scan, right? And then it's like, whoa, and then they recheck it on an echo, right? Either a transthoracic or a transesophageal, typically transthoracic, or an MRI. Again, we have a lot of technology because when you're looking at it with an echocardiogram versus a CT angiogram, which is probably going to be, I'm not a cardiothoracic surgeon, I'm not a cardiologist, but I'm an internist and I understand this stuff and I see it commonly with or without steroids, and people die from this. Just regular people getting older. Hypertension is the problem. Hypertension. So again, and when you get up to, I believe it's 4.5, they're going to send you, they're going to monitor it and they're going to send you to a cardiothoracic surgeon if you're not there already. And that cardiothoracic surgeon, he's the guy that will fix it and stabilize it, right? So there's aortic aneurysms of the base of the aortic root. There's ascending, there's mid, and then there's the abdominal aortic, AAA. Abdominal aortic aneurysm, and that's people that have smoked and have hypercholesterol. There's the cholesterol, right? Bullshit that cholesterol is this benign thing. That's embarrassing, guys. You got to stop this craziness. It's personalized. Not cholesterol doesn't hurt everyone. This old lady is 90 something, my grandmother, and she didn't have enough risk. Good for her. She's a woman. Go to an old folks home. I was in there. I used to work in nursing homes. I was medical director of a few of them. And I remember I was waiting for the nurse to bring me some. I was doing an incision and drainage of an abscess of one of my patients, minor surgery. And I was waiting for the nurse in the nursing home to bring me my tools. I was getting ready to put my gloves on and gown up a little bit just to keep it clean. And I like to do some of the procedures. And I was just waiting for it. It was taking a long time. And I was like, oh man, I gotta go. I gotta get out of here. And I was just looking at the nursing station. And I'll never forget. And I tell the story if you hear me over and over. I looked at the nursing station. There was about 10 people. It was midday. It was right in the middle of the day. And I looked at the nursing station. I saw, I don't know, it was like 15 people, mostly in chairs and wheelchairs, and average age 80, over 75, maybe 90. And there was mostly all women, and there was one man. And I just saw it, and I went, holy shit. Men don't live a lot. Now go to Google and put in, why do men not live as long as women? Heart disease. We're big dogs. Aneurysms, things like this. Hypertension, diabetes, ABC. Okay, sir, you want to please you can be on, if your doctor says you can't be on testosterone, get a new doctor. But don't go to some anti-aging clinic that is just cranking and giving you whatever you want. Go to one of my testosteronologists, for crying out. They're busy as hell. I know they can't even take patients anymore. You go on the directory of testosteronology and you'll see them. We're trying to train as many as we can, but I'm busy. We're very, very busy. And I don't do things hastily, and I don't do McDonald's medicine. So things take time. So you can be on testosterone. That dose is probably okay, but you have to watch your blood pressure, your A1C, your 75. And you better understand what's going on with your cholesterol and your dyslipidemia, with your HDL and your LDL, and you better check for Lp(a). You better have a great doctor to do this, and then you should take all these risk factors right to the ground. Hopefully you can afford it. Hopefully you have health insurance. Well, I know you have Medicare. But Medicare, unfortunately, doesn't cover all this brilliant stuff, sir. I used to be in Medicare, and I dropped out of insurance about 5 years ago. I've disconnected with the whole spiel. It's terrible. I'm coming out on my own. I got some secrets out here. I'm going to let it out. And again, I'm not going to go into politics at this point, but it's just like, this is disgusting that we have all this technology and people don't even know what it is, not to mention they can't get access to it because it's so goddamn expensive and your insurance company just denies it. Well, you have to wait till you're dead or just near dead with tubes coming out of your face and a bypass surgery? I'm gonna make some noise. Next question. Thanks for your response. A few days ago, I scheduled Lp(a), ApoB, and a calcium score. You're the best, doc. Thank you so much. I look forward to getting promote and budget to hire you as my. Thank you so much. Dude, this is the stuff that makes it worth it to me. Thank you, sir. See that? He's listening. Doctor, what do you think of a protocol 40 plus men every other day, sub-Q testosterone microdosing? I love it. If you need it, you're on testosterone, you're going to figure it out. Too much is not good, obviously. So microdose, dude. I like that. But then microdose it. How do you feel? You're going to see that, like, you're going to go, wait, this doctor, he says the same thing over and over. That's when you're a specialist. That's kind of what you do. So, but I'm doing ABCDs. I'm giving testosterone. I try not to give anti-estrogens because it's bullshit anti-estrogens. You shouldn't need if in the end I give anti-estrogens to my patients, I give it, but I give it sparingly because I manipulate the testosterone to get to a manageable estrogen level. Hello. Microdose, but again, make it simple, guys. Microdose the best you can, But if it's not sustainable because you can't remember to do it, or you can't even figure out that it's not going to work for you. Okay, that's why we have Nurse Wendy. She teaches everyone because she's the brilliant nurse. Next question. I'm going to be wrapping up here in a few minutes. What do you think about 65 milligrams of nandrolone on top of TRT for joint health? Love it. And here's what I love about it. Deca-Durabo and baby, test and Deca, old school. My shoulder hurts, my knee. So nandrolone is an incredible nandrolone-based NOR19 anabolic steroid that's pretty damn safe, right? If you get the real nandrolone baby doses. Now, a couple things. First off, if it works for the anti-inflammatory effects, if you will, for the joints, which is osteoarthritis or injuries and tendinopathies. Remember, I'm a power lifter and I'm 62 this year. Imagine how I feel. Imagine my body, how it feels. So if you use nandrolone on top of testosterone and it works, I give the same advice all the time. Again, I say the same thing all the time, but it makes common sense. You're going to go to the gym and it will feel better. But the problem is what's happening underneath, brother. Do you have tendinopathies? Do you have joint labrum disability? Right. I'm not an orthopedic guy, but I've taken care of so many professional powerlifters and I take care of the big boys. And I'm one of the guys. I'm not that big, but I moved a lot of weight. I'm still trying. I got to get my hand fixed to go back and bench 500. I mean, I'm still doing this, guys, but my hand is destroyed. I have to get a whole wrist replacement. I'm going to go up to New York City and get it. But then I got to take 6 months off of anything. I can't do yoga. I can't do my weights. I can't. Oh, man, I'm irritated. So I'm putting it off. But I can't bench heavy right now. And it's hard. First time since 13 years. 13 I've been doing this. So the heart and the kidney are good. You can keep going forever. That's my goal. That's my secret. Heart, kidney. So nandrolone, you're going to feel better on it. I mean, guys will typically use 100 milligrams. I know you know that. You're picking this 65. It's okay. I've seen everything. And then it will be okay. It will work. But the problem is it will stop working or you're going to hurt yourself and hurt your tissue because you're going to be training through it's like taking NSAIDs or a cortisone shot. It's really catabolic. This is not catabolic. This is anabolic. But is it sustainable? If you're just looking to do it to get through a powerlifting meet or a golf, again, I see guys you think about it. But then are you done after that? And then now, so that's the obvious acute orthopedic side of it. Okay. Now, and that's true. Guys learn this. So that they know, and can you live on nandrolone together? I have taken nandrolone for years at a time together. I'm not on it right now. I'm not on any. I'm just taking testosterone right now. Just chilling out. I'm not bullshitting you guys. I'm just chilling out and doing more yoga. I lift like once or twice a week to maintain the muscles, and I'm doing yoga right now, guys, and get ready to ride the mountain bikes up in Vermont. We're leaving this week. I'm so stoked, and I'm so humble and happy, really, for my health, my cardiovascular, sustainable. Someone asked me today, Doc, what? He's like 45, 50. He goes, what can I do to he doesn't want to do more steroids and testosterone because the side effects in his brain and his erections, he's in a good place, right? So he's like, I don't want to do that right now. I mean, how can I get bigger muscles? And I go, well, you're hypertensive. Let's treat your blood pressure. He goes, is that going to make my muscles better? I go, hold on a minute. Let's think about it. The reason why I'm old and I'm so fucking strong is that my endothelial, my heart, and my kidneys are preserved and really healthy. That's all. The last 20 years, that's all that's mattered to me. I kept it quiet, and when I'm pushing, and I'm in the bench and I'm push. Besides my hand on the machines, I can do a lot of these gyms. The crunch that I love, these new machines. I could rep out with the stack on some of this shit. I'm being honest. People look at it like, holy shit, this old man. My heart and kidneys are so invigorated and healthy that it comes right through my muscles. You have to understand that. When you're sick with any start of cardiac, when your heart is just starting to get hurt, you don't even see it and really feel it. and your kidney. I'm telling you, chronic kidney, you have to look at proteinuria. You have to look and understand all the stuff I'm telling you. Hypertension, sugar, and the cholesterol isms. I'm telling you. And when you keep it perfect for your fingerprint, you feel like a man. That's me. Your erections are going to be insane because that's health, vascular health. Okay, nandrolone. So you take nandrolone. Yeah, so it's really I don't think it's, I mean, I guess my shoulders and my back and my joints, they hurt so much sometimes, but they're okay. And I push through it and warm up, and I just know how to train around things. And I can't do certain things anymore. Just you gotta live with that and train around it, right? So, but in the end of the day, if you're masking the pain, nandrolone will do that. Is that okay for you? And when are you going to come off? And okay, so the amount of nandrolone you're going to do, could it affect your blood pressure? Go to Google AI, put in nandrolone steroid on cardiovascular issues, cardiovascular disease, and really, or put in heart failure, or put in nandrolone and cardiomyopathy. You see, I'm doing this now. I'm saying stuff to you guys, and I know you guys trust me and believe me, because what am I selling you tonight? I'm trying to help you. So I'm so irritated at this misinformation bullshit. So if you go to chat or any of these other Claude and put in nandrolone decanate, decaturable nandrolone steroid, tell me everything about the heart. Tell me about cardiomyopathy. Oh boy, you're going to go, holy shit. And that's what we've always talked about this for 20 years, me and the bro science guys. That's why if you use a little of it, even if you use it for a long term, which I think could be good, I'm going to go back on it. I love it. I actually like the effect for my brain. And for sexually, for me, I like the effects. Because it's just for me, because I'm on testosterone and we're not going to do the 2-to-1 ratio. This is old stuff. It's not ridiculous, but it just doesn't have to go that way. You do it yourself and you go by feel. Not every man is going to feel, every man's different. I feel good on this. This guy feel good. This is my life. All I do is testosterone and steroids with men. I've been doing it for over 20 years as a real doctor, right? Not a chiropractor. I'm a real doctor. Sorry. I'm so annoyed at this. And I feel like I don't know stuff, but I know the heart and the kidney and the red blood cells. Woo, testosterone and nandrolone. If you have problems with your erythrocytosis, the red blood cell stuff, not to mention the iron and the thickened blood, and you add DECA, go to Google, testosterone plus DECA. Tell me about polycythemia and thickened blood. Again, you're going to get whoa. So again, is it worth it for you? That when you start combining steroids for musculoskeletal effects, they're going to work. I talked about how that could work, where you could actually destroy your shoulder more. I've seen it. I take care of powerlifters. We're all destroyed. I've torn muscles off. I've torn the pec off the bone, distal bicep off the bone, both hamstrings down to the knees. I had 2 doctors in there. Okay. It's the territory, bro. That's what we do. We tear things off the bone when you're a good power lifter. It is what it is. The hamstrings were from a mountain bike. Thank God I didn't break my neck. Flipping over high speed off a big jump. Woo! A lot of adrenaline. So when you look at nandrolone, man, definitely one of the safer drugs, sustainable drugs with testosterone. Great effects for muscle building and even joint anti-inflammation. But is it sustainable? Is it going to hurt you? And how do you work around that? And when you come off it, you go, and why would you want to come off? But then again, watch the blood pressure. It's not going to affect the A1C, right? That's a good question, right? It's not going to affect the A1C, but it's going to affect the blood pressure. It's going to affect the myocardial tissue in the left ventricle and potentially cause heart failure with preserved ejection fraction or non-preserved, which is just heart failure with reduced ejection. That's standard heart failure. If you have heart failure in your genes, as you get older and you're again, I'm saying the same stuff over and over. It's all modifiable, but what are steroids going to do to it for today And then you have to think, guys, down the road. That's my life. Sustainability. That's on my grave. He's dead. It's sustainable. And I don't want to die to 120 or 30. I want quality of life, guys. Every day is the only thing that matters. One day at a time, like the program says. So in the end, you want to be careful with that nandrolone, and you want to really think it out and maybe run it for a while, see that, check your ABCDs, and then maybe, like I do, you come off for a couple of months and maybe go back on, and you get a feel for it, and you kind of, that's smart, right? And you do that with other healthcare providers, and you really are protecting all your organ systems and everything. You just having a great time, and you really want to live, the quality of life for your family, for your kids. And we have a new world, guys, with this technology. We have a new world. I want you guys to enjoy that. On that, I'm going to say goodnight because I got my tech team here and I don't want to keep them up too long. And we've been cranking for about an hour and a half. So I'll see you guys next week. We're going to have this recorded. This is going to be up on the YouTube. Get in the health portal. Do as much as you can with all my information. Thank you so much.